This is hypophosphatasia. Autosomal recessive, deficiency of alkaline phosphatase. Serum alkaline phosphatase is about 25% of the normal. Serum phosphorus levels are normal. Phosphoryl ethanol amine is found in the urine laboratory examination. Hypophosphatasia radiologically, there are several forms, particularly 4 forms. Congenital, usually they present with stillbirth, and decreased calcification, so-called tar baby, everything is lucent. Metaphyseal cupping, rachitic rosary, skull, plenty of vermian bones. And hypophosphatasia pathologically and radiologically, they show osteopenia, infantile rachitic-like changes, skull sutures are rather wide, and soft tissues may calcify and may also occasionally calcifications may increase with age. This is the infantile form. Look at the middle picture, tar baby, lucent bones, and the rest of the pictures marked bowing of the tibia and fibula, also rachitic changes. Hypophosphatasia in childhood, we finished with newborn, infants, and then childhood. Radiolucent metaphyseal bands again. Metaphyseal defects are pronounced, bowing deformities, and craniostenosis as opposed to cranial lacunae or vermian bones in earlier stage. Major endocrine glands. In adult type, you find almost, something like heel rickets changes. Now we come to major endocrine glands, the pituitary, the master on the orchestra, thyroid, parathyroid, adrenals, gonads, and miscellaneous like hypothalamus and pancreas. And there is hypofunction as well as hyperfunction, which reflect upon the bones. A 42-year-old woman with a loss of weight and painful swelling of the right hand. Look at the radiograph, you find a lytic expansile lesion in the metaphyseal end of the index finger or the second metacarpal, almost extending to the articular margin. This may be mistaken for a giant cell tumor. In fact, some of the lesions, when biopsied, they reported as giant cell tumors. But if you look at the entire picture, there is subperiosteal resorption of bone, subcortical resorption of bone, particularly in the medial aspect of the fifth metacarpal. All these combined together indicate hyperparathyroidism. Primary hyperparathyroidism, what are the radiological changes? Resorption of bone. This resorption of bone occurs in a variety of ways. Subperiosteal, subchondral, subcortical, subarticular, including brown tumors. After all, what are brown tumors? Resorption of bone with some hemorrhage. That pigment gives rise to the color brown pathologically. 30-year-old woman was referred to ultrasound of the neck with complaints of body pains, loss of weight since 2 years. That means clinically they are suspecting hyperparathyroidism. Ultrasonography, you can see a hypoechoic mass. And then color Doppler added to it, right parathyroid adenoma, laboratory investigations, calcium 11.5 milligrams, alkaline phosphatase 3000 international units. Radiological investigations for evaluation of further hyperparathyroidism. Color Doppler shows the increased vascular flow to the parathyroid adenoma. Scintigraphy, 99 technetium system B scan localizes parathyroid tumors in ectopic locations. Say, for example, substernal, mediastinal. In these locations, we can use the scintigraphy. And then to go further about the radiological manifestation on the skeleton, subperiosteal bone resorption. It occurs in the cortical bone, virtually is diagnostic of hyperparathyroidism. Occasionally, in fact, rarely, in immobilization osteoporosis also you may get some sort of a subcortical or subperiosteal resorption of bone. Most frequent along the radial aspect of the phalanges of the hand because of the stress of the thumb in grasping and other reflexes, in the middle phalanges of the index finger and also in the middle fingers. To continue, hyperparathyroidism is an increased level of parathormone in the blood. 3 types of hyperparathyroidism may result: primary, secondary, and tertiary. Primary hyperparathyroidism is autonomous hyperfunction of parathyroid glands, diffuse hyperplasia 10 to 40% of cases, single, only one adenoma 50 to 80%, or sometimes multiple in 10% of the cases, or carcinoma. Brown tumors, a little word about comment. Brown tumors are actually histologically osteoclastomas. They represent localized accumulation of fibrous tissue, giant cells, and with slight hemorrhage, and the bone shows expansion because of these things. Subsequently, they may undergo necrosis, liquefaction, producing cysts, single or multiple well-defined lytic lesions of the axial or even appendicular cyst. There is no exemption for brown tumors. Frequently eccentric and cortical in location. Look at the pelvis. Huge brown tumors involving the iliac and ischial bones. Same thing in the elbow. In fact, histologically, the diagnosis is osteoclastoma. The clinician curetaged it, but it recurred later. And look at the foot. I said there is no exemption for brown tumors. Any tumor can be, any bone can be involved with brown tumors. Here, this is the third metatarsal midshaft. Again, super scan. If you do scintigraphy, you get a super scan because of the avidity of the skeleton for the isotope, non-visualization of the kidneys. There is not enough to excrete into the kidneys. Everything is absorbed taken by the skeleton. In chronic renal failure, you can get what is called renal osteodystrophy syndrome. What are the 5 features? Osteoporosis, osteomalacia, osteosclerosis, soft tissue calcifications, including para-articular soft tissues, vascular calcifications, cartilage calcifications, and secondary hyperparathyroidism. Look at the Rugger-Jersey spine, classically described because of the dense articular bands with central lucency. That central lucency is just a normal bone, but it is exaggerated by the sclerotic bands on either side. Again, renal osteodystrophy with secondary hyperparathyroidism. In fact, in secondary hyperparathyroidism, we are seeing more and more brown tumors. And then vascular and soft tissue calcifications are also seen in the hand. Now we come to hypoparathyroid syndromes. Idiopathic hypoparathyroidism, no cause, we can't identify. Pseudo-hypoparathyroidism, pseudo-hypoparathyroidism, and post-operative hypoparathyroidism. When the parathyroidectomy is done, they may result in hypoparathyroidism. Radiologically, you may get dense bones, calvarial sclerosis, and premature closure of epiphyses, sclerotic bands of bone, ossifications of muscles and tendons, and bone-in-a-bone appearance, particularly noted in the spine, short metacarpals and brachypharyngia. These are the features of hypoparathyroidism. It's congenital or acquired syndrome consisting of dwarfism, to repeat what I said, brachydactyly, and also basal ganglia calcification in the brain, resulting in symptoms of extrapyramidal signs. Note the brachydactyly. Again, hypoparathyroidism, brachydactyly is pronounced, bone-in-a-bone appearance in the vertebral bodies. Pseudo-hypoparathyroidism. What is pseudo? It does not respond adequately to parathormone, but it resembles radiologically hypoparathyroidism. And then congenital syndrome again consisting of dwarfism with low serum calcium and high phosphorus. Calcific density is para-articular or the muscles in the soft tissues, limited to the deeper layers of the skin and superficial subcutaneous tissues. Pseudo-hypoparathyroidism again, 10% of them develop hyperparathyroidism. One has to be very careful. And you find all the radiological signs of hyperparathyroidism, disruption of bone of the proximal ends of the femora, metaphysis, fragmentation, displacement of the femoral heads bilaterally, necks are bent caudally. This does not appear to be rickets, because in rickets you don't get this fragmentation and all that. Again, in the feet, short metacarpals, it was fine, and in the skull, calcified dentate nuclei. Hereditary, short and obese hypocalcemia is present, hyperphosphatasia is present, but no response to parathormone. And then we get pseudo-hypoparathyroidism. It is incomplete genetic manifestation of pseudo-hypoparathyroidism. Blood chemistries are normal. Radiological findings are similar to hypoparathyroidism. Feet, 85% of them affected. Again, short metatarsals, 4th and 5th, short phalanges in about 25% of the cases. This 4-year-old child with the delayed milestones. Obviously, you see 4-year-old child, what all you see is 1 or 2 ossification centers, indicating the chronological age to be 2 years. Of course, you can get in so many conditions retarded bone age, but this particular case, it is hypothyroidism or otherwise called cretinism. Long bones, epiphyseal genesis is noted due to aberration of ossification pattern, fragmented epiphyses, sclerosis of the metaphyses. Spine, what do you find in this spine? Short and bullet-shaped vertebral bodies at thoraco-lumbar junction. You may mistake this for mucopolysaccharidosis, but there are specific changes in the vertebral bodies. Widened intervertebral disc spaces also noted here. Radiograph of the pelvis in a child, in a teenager actually, stippled calcification centers in the cretin you could see. A 5-year-old child with advanced skeletal maturation. You see, for 5 years, what are you get? You get almost all the corpus centers indicating the age to be at least 10 years. Advanced skeletal maturation. This occurs in hyperthyroidism. Radiologically, what do you find? Advanced maturation, particularly seen in the hands, osteoporosis, and if you look into the chest, it is a small, narrow heart. This case, a 37-year-old man with constant headaches. Notice the salata is widened, notice the thick calvarium, and also notice the prognathism. All these indicate strongly about hyperpituitarism or acromegaly. If you take the heel in a standing position, the thickness of heel pad normally should not exceed more than 23 millimeters. And if you look into the spine, posterior vertebral scalloping because of the hypertrophy of the dura, and of course the apophyses are slightly irregular. In the hand, the tufts are prominent, spade-like hands, the prominent tufts of distal phalanges, and then anterior and lateral hooks of distal phalanges also, and as well as the metatarsals, metatarsal hooks you find. Look at the thumb, the hooks in the distal phalanx. The same thing is found in feet. Hypopituitarism, proportionate dwarf, again osteoporosis seen, small irregular epiphyses here also, open narrow physis. Cushing syndrome, ACTH, dependent, pituitary Cushing's, ectopic ACTH, adrenal hyperplasia, these are all ACTH source uncertain. ACTH independent, adrenal neoplasm, either benign or malignant. Then multiple endocrinal adenomatous syndromes. Type 1, so-called Wermer syndrome, pituitary, parathyroid, pancreas, and plus some non-endocrinal changes are also noted. Same MEA2A, Sipple's pheochromocytoma, thyroid carcinoma, and parathyroid involvement. MEN2B and MEN3 also are noted. Again, to go back to Cushing syndrome, delayed bone maturation, osteopenia or osteoporosis, pathological fractures, and these fractures heal with pseudocallus or excessive callus, osteonecrosis, particularly in the epiphyseal heads or metatarsal heads, infarcts, and superimposed infection indicates that there is immunological deficiency, and septic arthritis also occasionally observed. Note the spine, osteoporosis with compression fractures and pseudocallus, density, wedging of the vertebrae with the density is noted. Hypoadrenalism is also called Addison's disease, calcification in adrenal glands. There are so many causes for adrenal gland calcification, including TB, hemorrhage, etc. Delayed skeletal maturation and growth, those are the hallmarks of Addison's disease. We come to female hypogonadism, or so-called Turner syndrome, mosaicism or partial deletion of a X chromosome, which may result in ovarian agenesis, 45 chromosomes. And then radiologically, what do you find? Sclerosis of bones, kyphosis, short stature in the chest, coarctation of the aorta, aortic stenosis. In the hands, short 4th and 5th metacarpals, hypoplasia of body of C1, pes cavus in the foot, drumstick appearance of distal phalanges, enlarged medial tibial condyle with depression, small osteochondroma on medial side of the tibia, and of course urinary tract, horseshoe kidneys. And clinically also you may see webbed neck and carrying angle at the elbows is obtuse. Turner syndrome again, short and 4th, 5th metacarpals, as I have said already. It is due to premature fusion of the epiphyseal ossification centers. Enlarged medial tibial plateau with enlarged femoral condyle. Again, I have repeated these pes cavus, hypoplasia, etc. Phalanges are not short as noted in hypoparathyroid syndrome. That is the key in diagnosing with a radiograph of the hand. Osteoporosis, and look at the wrist, small carpal angle or acute carpal angle. And in the feet also you find short 4th metatarsal. In Turner syndrome, look at the knee, medial condyle of the femoral condyle is hypertrophied and big with the depression of the medial condyle of the tibia. Occasional exostosis on the medial side of the tibia is also noted. Male hypogonadism, Klippel file syndrome. We will deal with male hypogonadism. This is Klinefelter syndrome, 47 chromosomes as opposed to Turner syndrome, 45 chromosomes. Male phenotype hypogonadism, positive metacarpal sign here also you may find. Radioulnar synostosis, small bridged cella that is variable, pseudoepiphysis in hands and feet, and osteoporosis and a tall stature. Also Kalman's syndrome associated with this. And now we come to toxic group, toxic materials which affect the skeleton. Steroids we have dealt with already, hypervitaminosis A and D, heparin overuse, dealing with osteoporosis, anti-epileptic drugs, producing rachitic changes, fluorosis, and heavy metals like arsenic, mercury, etc. Radiograph of the shoulder indicating osteonecrosis of the head of the humerus, this patient with corticosteroid therapy. On the other hand, if you look into the knee, there is also osteonecrosis, but look at the medullary area, serpiginous calcification with the fibrosis membrane indicative of infarct. Again, with corticosteroid therapy, to repeat, osteoporosis, osteonecrosis, and it affects the joints, resulting in neuropathic type of joints. Note in the pelvis, bilateral osteonecrosis of femoral heads. Same thing MRI. MRI is more sensitive than conventional radiology or ultrasound or scintigraphy. Cushing syndrome. Again, steroids and skeleton. And people have described Murray and Sweetnam in 1960. Now we come to fluorosis. Fluorosis is important, particularly in Andhra Pradesh, not only in India, because there are some endemic areas, including Andhra Pradesh, Punjab, etc. And the forms of fluorosis, clinically dental fluorosis, skeletal fluorosis, and non-skeletal fluorosis. India, 17 out of 32 states is endemic. And 66 million at risk, 6 million seriously affected. Look at the staining of the teeth. Clinically you can diagnose. Radiology, involvement of the axial skeleton is characteristics. Increased bone density due to increased trabecular condensation. Axial skeleton, hyperostosis, and bony excrescences at sites of ligamentous detachments, iliac crest and ischial tuberosity, enthesopathy, exaggerated enthesopathy. Calcifications, paraspinal ligaments, intraspinal ligaments, iliolumbar ligaments, almost simulating ankylosing type of spondylitis, but there you don't get sclerosis. And sacrotuberous ligaments, sacrospinous ligaments also. Occasionally it may simulate diffuse idiopathic skeletal hyperostosis. Periosteoids deformans, the degree of periostal bone formation is profound. Extensive osteophytes simulating exostosis, tendons, fascia, muscles being involved, soft tissue ossification resembling myositis ossificans. Look at the forearm bones. The interosseous membrane is ossified. That is the hallmark of fluorosis. Also look at the cervical spine. These interspinous ligaments, the posterior longitudinal ligament is also ossified. Now we come to hypervitaminosis A. This is due to educated women or uneducated women, their anxiety to treat the child with vitamins. They give high dose of vitamins, including A. Premature fusion of epiphysis, cone metaphysis, and periostal reaction, particularly the ulna, is characteristic. And then heel rickets or hypervitaminosis D. Again, it is due to enthusiastic parents giving higher doses of vitamin D. And for rickets, the deformities persist, but remember the metaphyseal cupping, all these are filled with exuberant new bone formation at the expense of other bones. That's why you see osteoporosis of the metacarpals and phalanges. Heavy metal poisoning, lead, particularly the Chinese invasion of metal toys. Now we are seeing more and more lead poisoning in children. Ingestion of metal compounds, inhalation of fumes, lead oxide in factories, inhalation of contaminated dust from clothes. Radiology mainly seen in areas of active growth, active metabolism, which is metaphyseal ends of bones. Dense and thick sclerotic bands, widened sutures in the skull, increased intracranial pressure. Differential diagnosis, any metal poisoning, bismuth, mercury, etc. Now we come to the so-called rare disease, which is not so rare, but it's uncommon in India. Metabolic madness was described. And in 12 years at Nizam's Institute, we have seen 78 cases. That shows the prevalence of this disease. Has a disease in the skull, wide diploid space, cotton wool appearance of the bones, sclerotic face, and picture frame appearance in the vertebra. It's bigger and more denser than the normal bone. Technetium 99, very sensitive to note the pagetoid changes in the entire skeleton in one sitting. In summary, ladies and gentlemen, it is a brief radiological presentation of the reflection of metabolic and endocrinal disease on the skeletal system.